Hello guys, and welcome to the second episode of Ahmedical Education. So let's do this case. A 75 years old patient was admitted to the hospital at 5 p.m. due to chest pain. So his chest pain is consistent with myocardial infarction. He has a retrosternal chest pain with radiation to the jaw, with radiation to the left arm. So we ordered an ECG to the patient, and the ECG is shown below. The vital parameters on admission were normal. His blood pressure was also normal on admission. So as you can see here, there is ST segment elevation in lead 2, in lead 3, and also an AVF. So this is consistent with inferior wall myocardial infarction. 6 hours after admission, you receive a phone call from the nurse, and she tells you that the patient is now confused. Now, you measure the blood pressure of the patient, and there is a blood pressure drop. So the blood pressure is 70 to 50, and you take the pulse of the patient. It is 40 beats per minute. So the patient has bradycardia, the patient is hypotensive, the patient denies any chest pain, but the patient looks confused. The patient has no fever. Physical examination shows Canon A wave on the jugular veins. There's also systolic murmur, and the patient, like I said, is confused, and there are no other focal neurological findings. You auscultate the lung of the patient, and there are no added sounds, so the lungs are clear. Now, what do we have here? So here we have a patient with hypotension, with bradycardia, post-myocardial infarction, or let's say, for simplicity's sake, a patient with hypotension post-myocardial infarction. So what is the differential diagnosis of hypotension post-myocardial infarction? So you have the following possibilities. Now I want you to pay attention that we categorize the possible complications according to the pulse. Does the patient have tachycardia, or does the patient have bradycardia? So this is how you manage them, or how you classify them. So if your patient has bradycardia and he's hypotensive post-myocardial infarction, you think about the first three possibilities. So either you were too aggressive with medications, for example, you gave too much beta blocker, or you gave too much verapamil. Well, this causes bradycardia and hypotension. Or if you only have a hypotension with tachycardia, so maybe you give too much nitrates. So this is the first possibility. The second possibility is called a Jarisch-Bezold reflex. So basically this complication, or this manifestation, is seen after an inferior wall myocardial infarction. So remember, the inferior wall of the heart touches the diaphragm, and when you have an inferior wall myocardial infarction, then you stimulate the diaphragm, which is supplied by the vagus nerve, and because of that, the patient will be nauseated, the patient will vomit, the patient will have bradycardia and hypotension due to stimulation of the vagus nerve. So it's a pretty benign complication, but keep in mind, patients who come to you, elderly individuals who come to you with vomiting to the emergency room, you have to take them seriously. You have to measure troponin, CK, CKMB, and you write an ECG, not to miss an inferior wall myocardial infarction, because sometimes this is the main presentation. The third possibility in this case, bradycardia and hypotension, is AV block. So AV block secondary to myocardial infarction, whether it is first degree, second degree, or third degree. Now, patients with inferior wall myocardial infarction, 5% of patients with inferior wall myocardial infarction may develop AV block or third degree AV block. So this is also important. Now, the causes of hypotension with tachycardia post-myocardial infarction are the following. Ventricular tachycardia. So the patient will be hypotensive and he will have tachycardia. Right ventricular infarction. We will talk about this. Cardiogenic shock due to myocardial infarction extension. So the patient is having inferior wall myocardial infarction, and now he is having a reinfarction of the left anterior descending. So the anterior wall of the heart is also infarcted, and this is called infarct extension. It's pretty common to see after myocardial infarction. Or one possible complication is cardiac tamponade. So there is a rupture of the free wall of the heart with secondary tamponade or papillary muscle rupture or ventricular septal defect due to a septal infarction. Now keep in mind these complications, these three complications, cardiac tamponade, papillary muscle rupture, ventricular septal defect, are due to necrosis of the wall of the heart, and in order for necrosis to occur after myocardial infarction, it takes 3 days. Now in our case, in our patient, the patient has bradycardia, and these cases are usually accompanied by tachycardia, so it's unlikely that our patient is having one of these because he's not tachycardic. And the second thing, our patient is having a myocardial infarction since a day. It takes 3 to 5 days for muscle necrosis to develop, for cardiac tamponade, papillary muscle rupture, and ventricular septal defect to develop. So this is also very important. Sorry, I just have to go to full screen mode. Now, what do you do in this case? It's always safe to give intravenous fluids to any patient who has hypotension. So start intravenous fluids to the patient, ask the nurse to write an ECG, and at the same time give the patient atropine. So in a patient with bradycardia, you will not do anything with symptomatic bradycardia, you will not do anything wrong if you give your patient intravenous atropine 1 milligram. Yeah. At the same time, while waiting for the ECG, try to examine the patient. So look for Canon A wave on the jugulars, which indicates AV block, third degree AV block. Put your hand on the pulse of the patient. Is there a pulse? If there is no pulse, then you think about either pulseless ventricular tachycardia, or you think about cardiac tamponade. So these are the possible two causes of pulseless electrical activity post myocardial infarction. We'll talk about it later. If you do feel a pulse, then try to determine whether this pulse is too slow or too fast. If the pulse is too slow, then you give atropine. If the pulse is too fast, then you think about other causes. You don't think about AV blocks or something like that. At the same time, try to auscultate for a murmur. So if you do auscultate a murmur, you might think about ventricular septal defect or papillary muscle rupture with secondary mitral regurgitation, or even pericardial tamponade. You should also auscultate the lungs. You look for RALs, for crepitations, which indicate decompensated heart failure. We will know why. We will find out in the next slides. So these are the take-home messages. The first take-home message is all life-threatening post-myocardial infarction complications cause hypotension. So all of these complications that we talked about them, which are pretty life-threatening, they cause hypotension. The second take-home message is all post-myocardial infarction complications result in tachycardia except sinus bradycardia due to medications, AV blocks, and Jarisch-Bizold reflex. So this is the second thing. Whenever you have bradycardia, you think about AV block, sinus bradycardia due to medications, or Jarisch-Bizold reflex, which is due to vagal nerve stimulation. The third take-home message is all symptomatic bradycardias are treated with atropine. Give atropine intravenously 1 milligram even before you write an ECG. You just put your hand on the pulse, or maybe you can measure the pulse with pulse oximetry. You see that the patient is having bradycardia, give him atropine. The fourth take-home message is AV block. Third degree AV block causes Canon AV waves on the jugulars. So basically what happens is in third degree AV block, the atrium and the ventricle, they're beating asynchronously. So the atrium sometimes contracts against a closed tricuspid valve, and the blood regurgitates in the superior vena cava, and it will transmit a pulse like a cannon wave to the jugulars. The fifth take-home message is if your patient is having Mobitz 2 or third degree AV block, then you need in this case a transcutaneous or a transjugular pacemaker. So these are our differential diagnoses for hypotension post myocardial infarction. Like we said, it's either due to AV block, sinus bradycardia, Jarch-Bezold. So these three conditions here, which are dark blue, these three conditions, they result in bradycardia. All the other conditions result in tachycardia. So in this case, what do you do? What do you do if there is an AV block or sinus bradycardia or Jarch-Bezold? So for AV blocks, for these three conditions, you have to stop beta blockers. For AV block, you administer atropine, and for AV blocks, you think about a pacemaker. If the patient is taking digitoxin, maybe he has digitoxin intoxication, so you might also use Digiband, which is a monoclonal antibody that binds digitoxin. Now, if your patient is hypotensive and he has tachycardia, then you think about the following complications. Ventricular tachycardia. Now, ventricular tachycardia, you have two different types. It's either with a pulse or pulseless. If there's no pulse, then this is called pulseless electrical activity. So this is ventricular tachycardia with pulseless electrical activity. Now, if your patient is showing signs of hemodynamic instability, for example, your patient is confused, which is the case, or hypotensive, or he has chest pain or shortness of breath, then this is an indication. This is an indication for shock. You have to shock your patient. And definitely you can use amiodarone. Now, I'm not going to talk about ventricular tachycardia. It's beyond the scope of this lecture. Right ventricular infarction. Any patient who presents to you with hypotension, with tachycardia, with clear lungs on auscultation, definitely plus a history of chest pain, then you think about right ventricular infarction. So patients with right ventricular infarction come with chest pain and they have tachycardia. The lungs are clear on auscultation, because if the right ventricle is infarcted, it cannot pump blood to the lungs. So this is why the lung is clear on auscultation. There is no crepitations. Definitely, in order for you to diagnose it, you do the right ventricular leads, which are leads V5, V6, V7, and you diagnose it. Yeah, these are called posterior wall leads. And how do you treat it? You give fluids. Now, another possible complication is cardiogenic shock due to infarct extension. So if you have an inferior wall myocardial infarction and you have an infarct extension, and now you have the anterior wall involvement, so you have a massive myocardial infarction which causes cardiogenic shock. So shock means hypotension and tachycardia, and this is why we have tachycardia. Now, on examination, if the heart is not pumping, you will have rales and crepitations, and this is why you always have to auscultate the lung in order for you to differentiate between right ventricular infarction and other causes of infarction. So here in cardiogenic shock you have rales also. What do? You have to do a cardiac catheterization, definitely. Cardiac tamponade. So usually these complications, like I said, these three complications, they occur after muscle necrosis, and muscle necrosis requires the 3 to 5 days post myocardial infarction. Yeah. So cardiac tamponade, the patient presents with tachycardia. This is another cause of pulseless electrical activity. So we have two causes whereby there is no pulse, and the patient has pulsus paradoxus, which is a paradoxical decrease in blood pressure more than 10 millimeter mercury systolic on inspiration. We will talk about it later. And also we have cosmal breathing. So cosmal breathing means, not cosmal breathing. Cosmal breathing is seen in diabetic ketoacidosis. It's called cosmal sign. Cosmal signs means normally when you inspirate, the jugulars in your neck will collapse. In cardiac tamponade, when you inspirate, when you take in a deep breath, the jugulars will engorge with blood. They will be filled with blood. It's basically a paradoxical movement of the jugulars, or a paradoxical distension. How do you diagnose a cardiac tamponade? You do echo, and then definitely you treat it with pericardiocentesis and surgery. Papillary muscle rupture. So again, it takes 3 to 5 days, and you can auscultate a systolic murmur, and because of regurgitation, the patient will have pulmonary edema because the left atrium will be also engorged with the blood, and the patient will have pulmonary edema, and the patient will present they will present with crepitations. So the patient is here decompensated. How do you diagnose this complication? You do echo and then you treat it surgically. Ventricular septal defect is another cause of decompensated heart failure after myocardial infarction. So basically you have shunting of blood from the left side of the heart to the right side of the heart, and this is why you have more blood delivery to the lung, and the lung will be edematous. And yeah, how do you diagnose this? There is a step in saturation. So if you measure the saturation invasively, if you measure the saturation in the right atrium, the oxygen saturation, and then you measure the oxygen saturation in the right ventricle, there is an increase in the saturation. So let's say the saturation in the right atrium is 20, the oxygen saturation, and then in the right ventricle it is 50 or 60. So you know there is a step in saturation, there is an increase in saturation, which is a sign of ventricular septal defect. So the things that you need to pay attention to in a patient who develops hypotension post-myocardial infarction are the following. The first thing, you have to measure the pulse of the patient. Does he have bradycardia or does he have tachycardia? If the patient has bradycardia, then you think about sinus bradycardia, Jarisch-Bezold, or AV blocks. You do your ECG and then you treat accordingly. And definitely you have to stop the medications that cause bradycardia. This is done. If your patient has tachycardia, then definitely you put your hand on the pulse. Does your patient have a pulse or not? If your patient does not have a pulse, then it might be a pulseless electrical activity. Either it is a ventricular tachycardia or cardiac tamponade. How do you know? You write your ECG and you do your echo. And definitely you can also auscultate the lungs of the patient. Now, it usually takes 3 to 5 days for necrosis, for muscle necrosis to develop. So you will only see cardiac tamponade, papillary muscle rupture, and ventricular septal defect after at least 3 days. So you should not be thinking about them on the first day. This is also important. Now, so what is pulsus paradoxus? Pulsus paradoxus, like I said, it is basically a decrease in the systolic blood pressure more than 10 millimeter mercury. So normally when we take in a deep breath, the blood pressure decreases less than 10 millimeter mercury. When there is a decrease of more than 10 millimeter mercury, then this is defined as pulsus paradoxus. You see pulsus paradoxus in respiratory diseases, advanced respiratory diseases like in asthma, and you also see it in cardiac tamponade. This is a classical sign. Now let's talk about it pathophysiologically. What does happen? Why does it happen? So, when you take in a deep breath, what will happen? The intrathoracic volume will increase. The intrathoracic pressure will decrease. This encourages blood return to the right atrium. Because the wall between the right atrium and the left atrium is very thin, so if you have an increased blood return, the septum here, the interatrial septum will bulge, and when it bulges, it will decrease the volume of the left atrium. A decrease in the volume of the left atrium means decreased blood return to the left atrium. Decreased blood return to the left atrium and to the left ventricle means less extension of the left ventricle, and according to Frank-Starling law, decreased stretch means decreased stroke volume. Decreased stroke volume means decreased pressure. So the blood pressure drops after respiration normally, but the drop is less than 10 millimeter Hg. If the drop is more than 10 millimeter Hg, then we think about pulsus paradoxus, which occurs in pericardial tamponade, and also it occurs in asthma and advanced respiratory diseases. So what are the possible causes of pulseless electrical activity? Now this is beyond the scope of this lecture, but just to be oriented, anything that causes obstruction to the venous return of the blood to the heart, or the right ventricular obstruction, right ventricular flow obstruction, results in pulseless electrical activity. So if you have a massive pulmonary embolism which is blocking the pulmonary artery, then you will have decreased blood return to the left side of the heart, and basically the heart will be contracting. So on ECG you see electrical activity, the heart is contracting, but there is no blood to pump, so you cannot feel a pulse. So this is why in massive pulmonary embolism you see a pulseless electrical activity. Ventricular tachycardia, there is a very rapid ventricular rate, but the ventricles do not relax, and this is why they do not fill with the blood, and if they don't fill with the blood, then there is nothing that they can pump. So this is why we see pulseless electrical activity in ventricular tachycardia. Not all forms. Ventricular tachycardia, there is ventricular tachycardia with a pulse, and there is a ventricular tachycardia with no pulse. Ventricular fibrillation, it's the same issue as ventricular tachycardia. Tension pneumothorax, we have tension pneumothorax, shift of the mediastinum. Shift of the mediastinum means the mediastinum will be squeezed, and the superior vena cava and the inferior vena cava will be twisted, and there is no blood return to the heart. Okay, so this is in tension pneumothorax. And one possible cause of pulseless electrical activity is definitely severe hypovolemia. In order for you to treat pulseless electrical activity, you have to find the cause. Definitely, if the cause is hypovolemia, you have to treat hypovolemia. If the cause is hypoxia, then you have to treat hypoxia. If the cause is ventricular tachycardia due to hyperkalemia, then you have to treat hyperkalemia. And if there is definitely a massive pulmonary embolism with hemodynamic instability, which is the case in pulseless electrical activity, then you have to give thrombolytics. Thank you so much. I wish you all the best.